This is Residents in a Room, an official podcast of the American Society of Anesthesiologists, where we go behind the scenes to explore the world from the point of view of anesthesiology residents.
Being kind, on the other hand, is sitting you down and having the difficult conversation of, hey, this is not going well. Is everything okay?
I kind of shifted my tone to very stern and being honest and I guess scaring him into staying into the hospital.
Avoiding these difficult conversations, I think, as we all know rationally, is actually going to cost more energy in the long term.
Welcome to Residents in a Room, the podcast for residents by residents. We're back again with Dr. Christopher Fadumiye to discuss how to manage difficult conversations with patients and families, and even with each other. My fellow resident is with me again, so let's run through a quick reminder of who's who. I'm Sabrina Muhanna. I'm a first year at SUNY Downstate College of Medicine, and we have Dr. Bayless.
Hi, I'm Spencer Bayless. I'm a CA2 at the University of Arizona in Tucson, Arizona.
All right, so Dr. Fadumiye, for last month's episode, we talked about how to thrive in residency, but for this episode, we're shifting gears to discuss difficult conversations. I'm wondering if you can talk about how to have these difficult conversations and how sometimes having these difficult conversations are the way that we're able to thrive in residency.
Sure. I strongly believe that at the heart of having difficult conversations, you really have to care about the person you're talking to or the message you're trying to convey to the individual in question. It could be a peer, it could be to a patient, it could be to a family member. And one of the things that I've kind of seen and noticed is a lot of people get bogged into this mindset of, I don't want to hurt people's feelings. And honestly, I strongly believe in the concept of radical candor. And I don't have to be nice to my co-resident or my peer, but I hold them kindness. I think being nice is having a difficult conversation that you have in mind, but choosing not to say because you're worried you're going to hurt someone's feelings. Being nice is you doing the wrong thing. And as an attending in the OR, I'm not telling you that you're doing the wrong thing because I think it's going to hurt your confidence. Being kind, on the other hand, is sitting you down and having the difficult conversation of, hey, this is not going well. Is everything okay? And so again, I think the spirit of difficult conversation has to come from a place of kindness. And it's not something that we should try and avoid because in a specialty such as anesthesiology, you're going to have people mess up, especially when it comes to trainees, and bad things tend to happen. And you also have situations where you have to talk to patients about difficult conversations. And when you start not learning how to do it the right way, you end up doing it the wrong way. And it becomes a problem when the stakes gets high. And I think with that in mind, I go back to, I don't have to be nice, but I can be kind and I should be kind. And in the spirit of kindness is me sitting down and having difficult conversations with whoever the individual is.
I hear you saying that kindness is very important and that ultimately being honest about the situation will, in a way, improve the relationship through being kind. What I'm curious about from a resident perspective is often it feels like the hardest part is not knowing necessarily what to say, but knowing when to say it.
So at the end of the day, when you go back to the old concept of having radical candor, for it to be effective, you have to have a relationship with the individual, with the person. If you have a true care relationship, or true relationship that's based on the concept of, I really do care about your well-being, then the question of what to say becomes somewhat secondary because you know the person enough to say, you know what, this is not the time to tell this person this hard truth. This is a better time to talk to this individual, but I'm still going to tell them this hard truth they need to hear. But what you're not going to do is not say it.
I think I worded my question poorly. That's actually what I was getting at. Because I think often you do know what you want to say, but it doesn't feel like the right time, or you don't think they're ready to receive your candor or your kindness. And so it's difficult to time that conversation.
I'm wondering also, like, when for example, for trauma patients, you're just meeting the family for the first time and you're not 100% sure about the outcome. How do you approach a family when they want certainty, but all you can offer is probability?
So again, the first thing you said is you don't know the patient well, right?
Mm-hmm.
But you also have to deliver hard information about, say, a patient's demise or an uncomfortable diagnosis or whatever the case is.
Mm-hmm.
So in that setting, what I would say is, in as much as you don't have a relationship or you don't know them that well, you can still come in with the space of caring. And what caring can look like in that situation is you have to be able to put yourself in their position and also be willing to listen. Now, it's so easy to just come in and say, you know what, I have to tell them this information. I have to go back and start my next case. Oh, there's another trauma coming in. It's 2 a.m. in the morning, and I have to move. I have to keep going. I think it's on the individual to recognize that, you know what, maybe I'm not the right person to give this information. Maybe
Mm-hmm.
someone else needs to give that information, and that's you caring in that regards.
Yeah.
And even when the information is being passed across, I think we also have to look at it from the perspective that the person you're delivering the bad news to is going to be riddled with a lot of emotions, anger, pain, they're mad at whatever the reason is that the information is being delivered. And they might take it out on you in their words, in the way they receive it, but you shouldn't take it personal. So I think the key thing here is, am I the right person to deliver this message? And if I am the right person, I should really listen because their emotions are not going to be rational.
Mm-hmm.
I should be able to take it for what it is and not respond in kind.
And I think that remembering that in these situations, the patient or the family members aren't speaking rational, like you said, is always helpful to keep in mind because it can really set the stage for, like you said, is this the right time or is this not the right time? So I'll keep that in mind for the future. But I guess also I'm wondering if the family, or the patient is in denial. I think that's also a difficult part of the job is sometimes patients are in denial about their prognosis or the family's in denial. And I think those conversations are also difficult. So how do you navigate through those?
So, and again, it goes back to what you just said, recognizing that they're going through an emotion that is not permanent. So they're in denial, they're dismissive, they're grieving the loss of a loved one. Those are not permanent emotions. And you are there in that moment to give care, comfort, bad information or bad news, but you also remember that they have to go and deal with whatever you're telling them, and they have to come back and continue to deal with it. So where they're seeing you and where they're meeting you at is not what they're going to carry on the next day or weeks after. And that speaks to the space of the institution creating resources and opportunities for people who are dealing with stuff to fall back on. So they have a terrible diagnosis, they're angry at the moment, but now they have to be able to pivot and say, you know what, where do I go from here? And that might not happen in that instance, that 10, 15, 20 minutes you have of giving them that information, that can happen later. And so with the information you're given, I think it's a responsible thing to always create an outlet for possible solutions or possible shifts of emotions. So, hey, you're feeling bad this time at this moment, but here's some resources for you to help with your grief, to help with your diagnosis. And they might not hear you in the moment, but you're still doing the work of giving it.
It feels like often, for me at least, my first instinct is to want to avoid these difficult conversations because of all the things you're saying. They come with negativity and a lot of emotional weight. But avoiding these difficult conversations, I think, as we all know rationally, is actually going to cost more energy in the long term, even when they are uncomfortable. But I am wondering if you could expand on how you go about dealing with that discomfort and even that hurt and that emotional pain in the acute setting.
Yeah, so I mean, it takes practice. And I think the first step is recognizing the kind of personality that we all have. Some people are avoidant, Some people are confrontational. Some people are regulated enough to have difficult conversations. And at the heart of it is just the emotional intelligence aspect of it. And it's something we all have to continuously work on. But I would say, though, that if you feel like you have that avoidant personality, I would work on that because, to be honest, you're going to have difficult conversations at some point. It doesn't have to always be with the patient. It could be with a spouse, could be with a friend, could be with someone you need to set boundaries with. And so I think practicing at the smallest of levels helps when it becomes a thing you actually had to have on the bigger stake. And if you're a
Mm.
confrontational person, then I guess learning to rein that back and become more emotionally intelligent and just understanding your own emotions. Why are you angry? Why are you trying to confront this other resident because they didn't show up on time to their case? And if you're the person who's already well regulated, I think it takes more practice as well. So ultimately, I think whatever category we all fall in, the work needs to be done because ultimately, what you don't reveal, you never heal. And so, don't have those conversations, it ends up becoming a bigger problem in the long run.
Yeah, well said. Because you brought up co-residents, I'm wondering too if you could talk through maybe if there's a different approach for going about these conversations with a colleague versus a mentor versus a patient's family.
Again, the situations and the scenarios are all going to be different. So with a co-resident, is this resident who is not holding their hand at the bag and they're not showing up to work, or is this a resident who is just very insensitive or other residents when it comes to trying to get out the cases and not giving room for everyone else to learn? And I think the nuances are very different and they matter in terms of how you deal with it. Ultimately, when it comes to talking to your peer, at the heart of it, you have to be professional. You're never gonna fight fire for fire and expect everything to be fine. There's a level of professionalism that is expected, and also there's a level of boundaries that you need to set, and there's also a level of clarity of intentions that you have to have when you're conveying what you're trying to convey. Now, they might not receive it well. They might not even agree with you.
Right.
What's not okay is just not doing any of those things, the things that you need to do. And again, it's always going to be different again because the scenarios are never going to be the same.
I'm wondering if you ever had a difficult conversation that went wrong.
A difficult conversation that went wrong. The answer is yes. Um, let's see. Do you want me to give an example?
Yes, please.
All right. So, okay, for the sake of for this conversation, I'll go back to when I was a resident. And one of the things I was grateful for my residency group was we had a camaraderie amongst ourselves where we all kind of like not necessarily all of us, but a good amount of us we knew, okay, you're my ally. If I need something, I can call you. But I've seen this in my resident class and the classes that came before and after me, and even now as an attendant, there's always one or two individuals where there's always some kind of like, oh my God, this guy is just not doing what it's supposed to do. And so in my particular case, we had a resident who was not showing up on time. He was not basically holding up his end of the bargain. And he would also go to the anesthesiologist in charge and say things that weren't necessarily true. I had seen him do it before to other residents, but then it was at that time it was like, okay, this is not my problem. I don't have to say anything. But then when he said it to me, it became a problem. When he said it
Yes.
to me. And so I had to pull him aside and had to let him know that this was not okay, that it's not fair to myself or the other people that he's going behind our backs to say things that are not true. And he apologized and he gave his perspective, which I listened to. But before we got there, there was a lot of back and forth, not so nice words shared, arguments, and voices being raised. And for me, that experience was eye opening in terms of just knowing that you can have the best intentions and you could try to do things the right way, but it always takes two to tango. And I had to recognize that in as much as I was trying to look out for myself and other residents who I felt were misrepresented in this particular situation, this individual didn't see it that way. That alone made it to be a very contentious conversation. And it was up to me to just say, you know what, this conversation is over. I am going to walk away.
I've never had a difficult conversation go wrong. I mean, I felt bad about conversations in the past, thinking about maybe I should have worded this differently, but I think it's probably more common with your colleagues for those conversations to go south rather than with families. So your example was great. I guess moving off of that, I think, at least for me, when I have bad patient outcomes and I have these conversations, I get very upset. Like, I think it just affects my mood for the rest of the day. And sometimes I have a hard time getting out of it. So I'm wondering if that's happened to you and how you navigated that.
Yeah, it does. I recall when I was a fellow, that was the first time I had my first bad outcome as a sole provider. There was a lot of crying. There was a lot of me just feeling emotionally drained and just sad. But going back to our earlier conversation on thriving, I think I had a great support system. They let me go home. They let me take the day off. They let me take the next day off as well, because they recognize that I have to be mentally okay to be present at work. And if I'm not, then I shouldn't be there. So with bad outcomes, I think it's on the individual to recognize that this is affecting me to the point where I need to take time to take care of myself first and just do what I need to do to be able to come back and be present for myself and the patients. Again, I don't know what your institution is like, but at some point, everyone is going to have some bad outcomes. But in the midst of it, in thinking about taking care of yourself, is you also thinking about taking care of the other patients you have to see the day after and the weeks after as well.
Hearing you say that, a question that comes to mind is maybe a more abstract one, but whenever I've been in situations like that, another difficult conversation that comes up and comes up repeatedly is the internal conversation I have with myself, and responding to that, like you said, with others with kindness can be difficult. So I'm wondering if you could maybe walk through how you try and go about doing that.
Yeah, so when bad outcomes happen, it's hard as physicians to not say, "Oh, what could I have done different?" That's a question that's going to always come up, whether you think about it or if it's an intrusive thought or if it's something that you just primed to think of. One of the things I found useful is falling back on my support system, my family, my mentors, the activities that I do daily that I take part into as a form of wellness. And like every emotion, the feeling of blame or guilt or just you thinking you could have done things differently, it's not permanent. It comes and it goes. And realizing that as time progresses, the severity of how you're feeling in terms of just how bad you're feeling also kind of lessens. But what shouldn't stay with you is the feeling that this is your fault, especially if it's you did the best you could have done. Ultimately, when we talk to patients, when we give them informed consent about anesthesia or whatever the case is, we always talk about the risk. Or there's a risk of having a major atherosclerotic event or whatever the case is. And one of the things that I always try to bring to mind to my trainees is, in as much as we take the best precautions to make sure everyone is safe, the risk is never zero.
Right.
And so bad things do happen. And when they do, it's easy to say, don't blame yourself. I mean, you're inevitably going to think you could have done something different. But remember that you did your best. Remember that the emotions and the feelings of guilt, shame, or whatever the case is, lessens with time. And you get there quicker by doing the things that you do to help take care of yourself, surrounding yourself with your family, surrounding yourself with your loved ones, talking to the people you need to talk to, getting therapy if you need to get therapy. And that's how I would navigate difficult situations when I'm dealing with bad outcomes.
Yeah, thank you for that. And I'm wondering now if you could expand on, you brought up consent and explaining risks to patients and those conversations can pose challenges as well. Can you expand on how you approach those conversations and what us residents need to know?
So I'll start off by saying that I don't know what your institutional policy is. I would say get familiar with your institution's policies, but notwithstanding, when you're getting consent, you have to listen to the patient, and you also have to understand what you're truly getting consent for. It's a lot harder to go into the nitty gritty, but I think understanding what the institution's policy is helps you know what you ask consent for. Because sometimes the consent is already obtained from the surgeon's consent, or sometimes you don't even need to get a consent for certain things. And so again, to understand that, and also just go in with the attitude of caring and listen to the patient and answer their questions. And those are the big things I would say in terms of just getting consent.
I have a question. I mean, just something that I've wondered as we've gone through this conversation is, we have our surgery colleagues with us in the OR, and there's times where we don't anticipate a bad outcome, but it ultimately happens. How do you navigate speaking to the family as the anesthesiologist versus knowing that the surgery team is also going to speak with the patient? I don't know if that's ever happened to you,
Yeah,
but
that's a very relevant question. So the key thing here is realizing that this is a team effort. You're not just providing anesthesia, and the surgeon is not just doing surgery. It's a collaborative effort. And so if there's an outcome that's not so great, it's on the team to have a debrief. It's on the team to have conversations around, A, who's going to talk to the family? Who's the right person in the right frame of mind to have this difficult conversation with this family at this point? Because sometimes it might not even be the surgeon. Sometimes it might not be you. And so I think having those guardrails and conversations beforehand helps in terms of just putting the best person forward to have this conversation with the family. And that's how I've done it, and that's how we do it in my institution. There's always a conversation about a debrief and having conversation about who is the right person to go have this conversation at this particular time with the family.
now that makes sense. Like, it's possible that the surgery team will have a more good rapport with the family. So it makes sense to have a debrief. And also for our own understanding, debriefing what, the outcome, what we could have done better, what we did well is always great. We do that after codes here, and it's very helpful.
Yeah, I think it's a good practice to take into when having conversations with family about difficult outcomes. And like you said, it's also helpful for you guys to talk it out to see what you could have done better. All right, so is this a good time to ask you guys questions? Are you guys ready?
Yeah, I'm okay with it.
I'm ready.
Okay. What are you guys seeing in your practices in terms of how these conversations look like? And have you guys seen anything entirely different that you'd like to share?
I can speak to something that actually happened to me yesterday. I was working in the ICU, and it wasn't a difficult conversation in the sense that I was delivering bad news. It was a difficult conversation in this patient was very resistant to getting treatment for his condition. And I don't think that he was really aware of how guarded his prognosis was. So initially, it was overnight in the ICU, very young male on two pressors saying he wants to go home. And I was saying, sir, you're very sick. If you go home, there's a very big chance you will not survive. And he was kind of in denial about it. So I took the nice approach with it. And then he once again was telling the staff he wanted to leave, was like just being very agitated. And I kind of shifted my tone to very stern and not scary, but, being honest and I guess scaring him into staying into the hospital. It was my first time speaking to a patient in that setting. So I didn't know what to say, but I wanted to, in my mind, I wanted to just shake him and be like, please, like, stay here. You're really sick. But I obviously couldn't do that. So I kind of just stuck it to him. I was saying, you will die if you leave this hospital. And whether or not you believe your medical team is up to you. But I also tried to get to the root of why he was not, I guess, receptive to what we were saying. And lo and behold, I do think he was just encephalopathic because I think he just wasn't in his right state of mind. I mean, I obviously found that out after, but it got me to thinking sometimes you have to have these difficult conversations, not about poor prognosis, but how to properly show your role as a clinician and getting your patients to trust you while still being able to explain that their prognosis is guarded. So it was just a very interesting scenario yesterday, but I will remember it for a while.
It's good. It's good.
I think I'll expand on that because what it brings to mind for me is that often what I see in the conversations I've been having and I've had throughout residency and my personal life is that they're often centering around some sort of unmet expectations or misunderstanding of someone's goals for a certain situation. And again, whether it be with patients or families or within the teams you're operating. And I've seen that really when we're having resolutions and you're having good outcomes from these conversations, it's coming from shifting from trying to defend your own position and instead getting to a point where you're clarifying what each other's expectations are, what each other's goals are, and how you get there in a way that's collaborative and that benefits everybody.
Yeah, I definitely think that would have been helpful, just understanding his expectations for us as his ICU team, and our expectations for him as a patient. I definitely think the conversation would have been more productive. So we'll keep that in mind for sure.
That's good to hear, guys. Where do you go for help when you're struggling with difficult conversations?
I think it depends on what the situation is. As we've touched on, there's so many different situations. Some involve families, some involve colleagues at work, etc. If it is, a difficult clinical situation, then I rely on the attendings who have been mentors in that area that have helped me with difficult situations in the past, that have shown me firsthand that they approach these situations well and that they have good outcomes. And then for interpersonal issues, it's my family, my dad and my mom. They're big inspirations to me, and they've made me who I am today. And so I rely on them still for a lot, especially when it comes to managing difficult situations and conversations.
I am very fortunate to have great chief residents. They, from day one, have said my door is open, my texts are open, just creating a very safe space for me to feel like I am not bothering them with things. So I'm very thankful for my chiefs. But I mostly go to them with like very big things, small things, which, arise almost every day. I have an excellent like camaraderie with my co-residents. We're all there for each other, especially, we're all in the same room. We're doing medicine. So we see each other a lot. So we've been able to build some pretty special bonds. But like Spencer said, my family is always there too. Like my fiance, my mom are very big. I have my cat, talk to her. She doesn't really talk, but
Perfect.
she's wonderful. She does what she needs to do.
I think that's a great point you bring up about peers that I utilize regularly, and I hadn't thought of, is that they give you a nice little sanity check sometimes before escalating things.
Yeah. I'm glad you guys have all of those outlets and resources to engage when it comes to difficult conversations. I guess the last question I have is, so difficult conversations are things that, like I said earlier, you have to get comfortable with. What have you seen in terms of your personality that has kind of served as and again, this is individual, everyone's personality is different. What part of your personality do you see as an hindrance in preventing you from doing the self-work to having these difficult conversations with family, friends, peers, or wherever the case is?
I think, like I mentioned earlier, I do struggle with like overthinking my decisions. something like I said, I have been struggling with. So I think that's really the biggest barrier for me is thinking about what I want to say, when to say it. Like we've been talking about, it's just understanding when to speak up and the right times to speak up. But when you're dealing with it alone, say you're on like nights by yourself, you don't always have people to discuss with and get their thoughts on. I mean, you have your attending, but I think the biggest hurdle is just being confident in your ability as not just a clinician, but like a human being to speak to a patient. So just kind of throwing everything I learned out the window and just speaking, it's going to sound cliche, but from the heart rather than overthinking what you want to say during these conversations.
Yeah, and I think for myself, it's something I alluded to earlier, and that I struggle often with overthinking the timing of having these conversations and the impact it'll have in the right now rather than the impact that not having the conversation is going to have. So I sometimes struggle with that and getting myself to realize that the immediate discomfort is going to pay off with avoiding that long-term discomfort, and that saying something is often better than just saying nothing.
All right, that's all the questions I have. This has been really great, and I hope you guys have taken something worthwhile from this. And thank you again for the invite.
Yeah, of course.
Yeah.
Thanks for being here.
Yeah, thank you so much.
So another really great, helpful conversation. Thank you so much, Dr. Fadumiye. I learned a lot from this, and I'm sure our listeners did too. And thanks to our listeners for joining us. Come back soon for more Residents in a Room, the podcast for residents by residents.
Hello, ASA. I'm Dr. Patrick Guillaume, your ASA president, and this is the Monday Morning Minute. First, recent communications from South American societies describe healthy patients who suffered catastrophic injury and death after routine general anesthesia. I encourage you to review the guidance issued by ASA and SPA. Next, ASA's Advance meeting in Vegas had record-breaking attendance and outstanding keynote presentations on communications and resilience. And last, the Joint Commission updated its accreditation manual for acute care hospitals regarding who may administer anesthesia, removing student nurse anesthetists. Anesthesia groups may wish to review and consider amending their policies and procedures. Well, that's it for now. I hope you'll follow us on your favorite social media channels and check out my weekly Monday morning outreach.
For more detailed and timely information, don't miss Dr. Guillaume's Monday morning outreach email delivered exclusively to ASA members' inboxes every Monday at 5 a.m. Eastern. With a focus on content and information not widely or publicly available, BeaconBot fetches answers to your questions by searching through anesthesiology, committee resources, and statements and guidelines. Try it now at asahq.org/BeaconBot. Join us for Residents in a Room, where we'll share timely info, advice, and resources designed to help residents succeed in residency and beyond. Find us wherever you get your podcasts or visit asahq.org/podcasts for more.